Ready? Okay, awesome. So we've made it through a couple already, our introductions, and just again, a little bit of what we'll talk about this morning. We wanted to lay the groundwork to help you understand what standardized screening and assessment has looked like in Kentucky, of course, what we've learned and where we hope to go. So I do think it's important to see kind of the lay of the land. In Kentucky, we have a statewide child welfare system that's split into 9 service regions. So each of those service regions have a service region administrator that oversees the support staff that provide services to youth and families. We also partner with the Department for Behavioral Health, which is broken into 14 service regions, and each of those regions has a community mental health center, again, providing services to the community. We also have a wide variety of private child placing and private child caring facilities across the state, and independent providers that provide outpatient behavioral health services to youth. So it's complicated, right? I'm sure, like many of you, you work with multiple providers. This adds to the complexity in how we share information and how we communicate with each other. And so we have historically seen a lack of alignment around the processes within different agencies, and yeah, what that looks like. So it makes it difficult to collaborate when we have people all over the state, different regions, some overlap, and how do we build relationships across regions, and that becomes challenging. So like many of you, my kids made fun of me for the silos, right? But we know what this means, that we all work in these different silos. We have our private child caring agencies that are providing therapeutic foster care. They tend to work in their own silo. Child welfare tends to be siloed, and then behavioral health. And so really the challenge is, how do we bring those together? Where are we one silo? This is where the joke. Are we one silo? Do we want to be 6 silos together? And I was like, okay, it's just an image. But we've seen lack of standardization around what happens when children enter into the out-of-home care system. So there's really been no standardized way to make decisions about who comes to the attention of behavioral health providers or when that happens. On top of that, all of our providers use a different assessment, right? So youth are referred to an agency, placed with an agency, and everybody has their own checklist. Everybody has their own format, and some of those assessments are quite thorough and comprehensive. Others are checkboxes. I've seen them. And so when sometimes those reports get back to the child welfare worker, and sometimes they don't. But oftentimes they're lacking, right? So they may not include all of the information. They may not have engaged with the family and gathered enough information to support the work. But DCBS workers also are not trained to interpret clinical information. So, they might have to Easter egg hunt through a report to find one thing, one recommendation that they can put into a case plan. So we introduced Project Safe Space, and Project Safe Space was a 5-year federally funded grant, and some of the goals of that were to redesign the behavioral health service delivery system to be more responsive to the needs. So wanting to create a more proactive and less reactive system to work with youth in out-of-home care. We wanted to conduct universal behavioral health screening for children in out-of-home care by their child welfare worker. And so we use 5 screening tools to identify trauma and behavioral health symptoms that are concerning as youth enter into the out-of-home care system. It has to be completed within 10 days of entry. We use the Young Child PTSD checklist, the Strengths and Difficulties questionnaire, the Child PTSD Symptom Scale 5, the Upsetting Event Survey, and the CRAFT, so looking at substance use or misuse as well. Again, those screeners are completed within 10 days of a child's entry. And then we wanted to, on the other end, implement a functional assessment for youth in out-of-home care in private child caring agencies and community mental health centers. That's where the CANS comes in. So if a child screens in and meets certain clinical criteria, then they would be referred for a CANS assessment. All of this information helps us to inform assessment-driven case planning and evidence-based treatment, working with these youth, help to improve the social and emotional well-being of youth in out-of-home care, and inform agency and system-level decision-making regarding the processes and the practice and capacity building. All right, make sure. All right, so a brief walk through our timeline, and then we'll kind of catch you up to speed on what's happening today. We received the grant in 2013 and immediately began a needs assessment process and formed a steering committee of folks from the Department for Community-Based Services, Department for Behavioral Health. We partnered with Eastern Kentucky University for training, the Kentucky Partnership for Families and Children, and University of Louisville. So almost forgot ourselves. But we partnered together to build this team to begin implementation of, we have these overarching goals, knowing that we needed to implement this process, and made decisions around the tools, partnered with the TCOM team to build the Kentucky CANs, and we started implementing in some counties in 2016. However, we had partnered with a vendor in Kentucky who was going to build a CANs web-based application for us. And several months in, they realized they were in over their heads, and so our progress was delayed. Eventually, we were able to partner with Advanced Metrics and build our system, but we did have clinicians that were doing CANs on paper for several months before we were able to start that web-based process. In 2018, June 1st of 2018 was an exciting day. That's when we were able, we achieved our full state implementation. So every youth entering out of home care since June 1st of 2018 has had a screener, or is required to have a screener completed, and if screened in, should be referred for the CANs. And then, just less than 2 years after our full state implementation, we experienced COVID. And while we moved from in-person training supports, being present in agencies, offering all of this on-site clinical consultation, in-person trainings, we immediately had to pivot and started providing everything virtually. But like probably many of you, our state experienced significant burnout, turnover in both child welfare and behavioral health. So I know yesterday in one of the sessions, someone mentioned, we have an entire workforce that it seems have started since the pandemic. So these folks were not around when we really laid the groundwork of the grant and don't always understand and connect with the purpose behind screening and assessment. They don't know what the system was like before we did this. So that's a difficult barrier that we have to overcome. So we've continued, and today, 10 years later, we are really looking at, what do we need to do? How do we expand the work, which we have, and how do we get back to the basics and ensure that what we're doing is working for youth and families? So, okay, I think that's me. I'm going to pass it on. Do you want? Sorry, one more. Thank you. But one thing that we did that was really exciting to help move us from this grant-funded project, right? Because there are a few folks that are in the room today, I'm looking at Christy, who probably, when we came to their agencies and we went to child welfare workers and said, this is what the practice is, they're like, yeah, we've been a part of 1 million grants and we know this is going to go away. So you're going to run out of money and we're not going to have to do this anymore. So we'll do it until we won't, right? But we did take a few steps to really try to solidify this in practice. And so one of those is we built the screening tools into our SACWIS system so that when child welfare workers complete screening, it goes straight into SACWIS, it's scored in SACWIS. They can then send referrals to agencies and we can track that better. And then using the CANs and really trying to implement that into practice, we've built an interface between the CANs system and our child welfare system so that when the CANs is completed, the social worker gets a notification and is able to review that assessment. So the CANs has also been implemented and used with the QRTP assessments in the state of Kentucky. So that's another way that we're seeing the information integrated. All right, hand it off.
All right, so whenever we think about implementing something as large as screening and assessment statewide, as you can imagine, there are multiple systems we're talking about that need to talk to each other. There are IT systems, there are people systems, all sorts of ways in which we need individuals to collaborate. So as Lizzie indicated, the grant wrapped up in 2018, and in 2021 and 2022, we implemented a mixed methods study. We ran focus groups with behavioral health providers and child welfare staff, and conducted an administrative data analysis of screening and assessment data over time. And that's what we want to share with you today, so you get a sense of where we are. So for the focus groups with behavioral health providers, we held 11 focus groups. We were strategic in the way in which we created the groups themselves. As Lizzie indicated, there were some agencies that were on board with this early on and bought into it. They had agency buy-in, and other organizations that had less buy-in. So we broke those up into high compliance organizations and low compliance organizations, hoping that we could understand some of the facilitators and barriers to CAN's implementation within their organization. And we could glean some insights from those that are implementing it well, so that we could then carry that forward with those that are not implementing as well. And as you see here, Lizzie went through like what the different letters mean there. All right. So the first thing we want to talk about is the theme of how do clinicians understand the purpose of the CAN? So like, what do they even think about it? Facilitate, and the themes that came out from that: facilitate communication between, this has a little laser, Dale, so I'll just do that. Facilitate communication between DCBS and behavioral health and the courts, facilitate getting services children need, connect to the treatment plan, periodic measurement of needs and risk, and track progress over time. So I always find anytime you have focus groups, the real gold of those are direct quotes from the participants, because that's really like they are telling you what's going on. So it's best to just let their words speak for them. So for the purpose of the CANs, it gives the workers and the judge the same language that I have in understanding treatments, barriers, and strengths. The CANS assessment gives us this kind of shared understanding across every facet for the adolescent. And the CANS is supposed to aid in case planning, seeing what the child needs, serve as a baseline, the initial, and then monitoring progress. So if you look at some of these, you're like, wow, they're really, they understand it. They understand the utility of it. They understand the benefits of it. So then how do clinicians gather information to complete the CANs? One of the things that I would think most clinicians and DCBS providers would know here is that a collaborative approach is really our best approach, right? Especially when we're talking about kids. We want to gather information from as many individuals, collateral contacts as possible, so that we can get a full picture of what's going on. And I think that's what you're going to see in some of these quotes here. So information collected from the biological and/or foster families, other previous assessments and paperwork, interviewing the youth, DCBS workers, and school staff. So the first quote here really highlights that trying to make contact with families, because they realize that's such an invaluable piece of the puzzle. The second here, they like to see what's in their system, so they're gathering it from other areas of paperwork. And then for this one, they talk with the case managers. So then, your gold standard is during our intake process, we normally meet with the youth. That's who you want to really hear from. Normally meet with the youth, do an interview with the youth, interview the family, and then try and get as much information from possible as everyone who is willing to cooperate. So as we see here, it really is a collaborative approach to gain as much information as you can. How do clinicians use the information from the CANS assessment? So clinicians use the CANS in the following ways: treatment planning, clinical decision-making, assessment, measuring progress, and some also indicated that they see limited value in it. One of the things that when Lizzie and I were putting this PowerPoint together, presentation together, it's like, okay, so do we only share the good stuff? Or do we share the good stuff and the reality of implementation when you talk about implementing on this large of a scale? And from our perspective, it was better to just share it all, because there is a potential for you to connect to some of the what's not going so well also. So in treatment planning, we have a treatment team meeting once a month that has these individuals with it. They bring the results of the cans to the treatment team meeting because that helps them determine where they are at in their program and what milestone they should be placed. Clinical decision making, the clinicians formulate the clinical decision. And then it's supported in the results of the cans. For this particular one, it's finding the right fit for service. As I'm sure most of you could connect with, like service equity and access is such a huge issue for youth, and finding the right service and the right provider that meets that particular person's needs. And then measuring progress. I'll do the cans, and then the therapist, she actually writes the goals and objectives after reviewing them. We'll choose certain ones to work on for the initial treatment plan. One of the things I do want to point out here, so again, large systems, agencies have latitude to sort of develop systems and how they want. Some organizations have an intake provider or intake worker that does all of the paperwork, does all of the assessments, and then hands it off to a clinician. So that's what you're seeing here is there was an intake worker who then handed it off to a therapist within the agency who's doing the work with the child. And then some barriers. So providers not receiving the screeners or important other information. So I'd mentioned earlier that whenever you talk about implementation on this large of a scale, there are so many systems that need to connect and need to talk. We were actually just talking about that with AMS, and the number of times data is handed off before we ever get it at the University of Louisville to do our data analysis. So there are so many ways in which that data is touched before it ever gets to the analysis point. And I think that's part of what you're seeing in this quote here or this particular theme here. And then technology and computer challenges, time consuming, lack of ability to contact the biological family, the availability of CANS assessors, and the child is moved before the cans is due. So these are some logistical barriers. And then for contextual barriers, part of what you see here are difficulty connecting the cans and completing the cans in the established time frame. So providers have 30 days, I believe it is, Lizzie, to complete the cans. So that matches oftentimes what the State Department of Mental Health will align with for other assessments. So they connected the cans timeline to that. Providers' lack of understanding of the process. As Lizzie said, so this is 10 years in. So Lizzie is actually, we can clap for her later. She will have her finish her DSW here in just a few months. I'm on her committee and so excited for her. So she she is doing a separate study on collaboration and where we are at this particular point. So I think what we're going to find, I'm so curious about this, is 10 years in, how many of the individuals providing service now were actually part of the original demonstration grant. She was just commenting earlier, you can tell your own story, Lindsay, but she was commenting earlier that she has a question about that. Like, were you did you work at your organization up until June 1st, 2018? And primarily the responses are, I don't know. It's like, do you not remember your hire date? Where was I on this date? So,
Be good.
yeah.
I'll share more in San Francisco next year, what I learned. So
Yeah, we're excited, but that was just, I was curious. Anyway, okay. Clinicians don't find it useful in treatment. So really, I think what you're seeing there is like the way in which the CANS is constructed. Some clinicians, there's always this idea of like the clinician feels like I'm the only one that can make these decisions, that sort of thing. So the idea of using standardized assessments versus just your own clinical expertise. The Kansas subjective, limited provider agency, internal processes. Again, when we think about the layering here, and then provider hesitancy to use assessments completed by others and questions in the CANS don't fit. So a summary of that before I hand it off to Lizzie. Clinicians are utilizing the CANS assessment in various ways. One of the things that was implemented earlier on was a liaison with DCBS, and I sort of joke about this. One of the quotes that we have for that is the provider used the word love. I love our DCBS liaison. She's so helpful. She gives us all this information. So knowing that the clinician has essentially one place to go to connect to who's the caseworker, where can I get this information, that sort of thing. That's really the liaison's job. And you see that being an invaluable position, really. And then high compliance agencies both have some effective strategies for implementing and also struggle with aspects of the CANS assessment itself. And then for contextual barriers, I think one of the things, the project initially was implemented with youth and out-of-home care. As such, completing the family and caregiver needs component of the CANS is a challenge, right? Because it's youth and out-of-home care. So we are now moving forward with statewide implementation of completing the CANS assessment and screening assessment processes for youth and in-home care. So we'll be curious to see about that. Also, assessment of age youth 0 to 5. So you'll see a little bit more about that later. And then assessment of youth with developmental delays.
Okay, so we'll switch gears a little bit and talk about what we learned in the focus groups from our DCBS staff, so our child welfare staff. We held 5 focus groups with them, and we'll share on the next slides a little bit what we learned. It is interesting that we have 9 DCBS liaisons, and 8 of them were able to participate in the focus groups, and their role is really key to this process working because they are the link between the child welfare agency and our behavioral health provider agencies, especially youth that are receiving services from our community mental health centers and other outpatient services, because they really make sure that when those kids are screened, the issues are identified, that they are able to be referred quickly to an appropriate CANS trained provider. So a few of the themes, and again, they're not all good. I mean, they are good, right? Because it is good to know what's happening. We have to have some pulse on how people in the field feel about what's going on. We asked a lot of questions of the DCBS workers, but again, in order, like for this presentation, really just want to focus on their understanding and use of the CANS. So how do they see this tool? The first question is just how do you access it? Because in an ideal world, you would access it through the SACWA system. That's why we have the interface and the data exchange. Workers get a notification, and so they should just click that notification and review the CANS assessment report that's returned to them. So, about half and half, or about, over half the people said that they're accessing the report through TWIST, but they also found that the CANS report could be useful in case planning, which is great. That's what we want, right? We want them to use it to inform case planning for the youth and the family. Some folks said about split, that it's used in supervision and consultation and that it's not used. So again, just some of those quotes. This is a overzealous, I think, behavioral health provider, which is great. So they're emailing the worker and saying, hey, I did the CANS and you should get it in TWIST, but here's a copy anyways, just in case, which is good, right? So we're having that open communication, sharing that information. I like this worker talks about, we had some questions that came up and we were able to jump into TWIST, and which is again our SACWIS, and look at the CANS assessment report and see what that says, what the clinician is reporting about the child. Again, this is from a liaison about uploading. Some of our terminology is sometimes wrong because they don't have to upload anything. They just put it in the system and then it's transmitted to TWIST, but for that worker to get the notification that they can review it. Again, folks that are using the CANS in case planning, one of the things that we see, and I'm sure, we cannot be the only ones, right? That we have the child welfare, they meet frequently and talk with internal staff about what's happening on a case. Our private agencies have, treatment team meetings. They invite the child welfare worker, but they don't show up. There are lots of things happening and planning, but not always bridging that gap and bringing everyone together, which is, of course, the ideal. So on DCBS, they look to see what the therapist is saying and recommending on the cans, and how that's being addressed. This worker says at the 6-month case planning conference, somebody asked, "Hey, did you look at the cans? Did you see what's recommended? Are we checking in on that progress?" This talks about staffing with the supervisor when a case transfers from investigations to ongoing. If a CANS has been completed, then they're able to refer to some of that information and share it as it moves to an ongoing case. I do like this. I appreciate this. Some of our regions, so, again, with our statewide child welfare being split into those 9 service regions, some regions have really incorporated into their daily practice. So this region, I think, changed their case consultation sheet and put a note on there that says, review the CANs, right? So that just reminder of, we have this information at our fingertips. Let's check it out. And then on the flip side, not used in supervision or consultation, you discuss all of the case aspects, and this person reports that really it's more about compliance, which we've seen pretty heavy a focus on compliance. Are you doing it? Are you not doing it? And not even are you doing it well, just is it done? And can we check that off of our list? And so that's what this person is saying as well, that it's more they're past due or they're not updated or never were done. I think what this person is saying is consults, are being held without people realizing it's anything related to the CAN. So maybe those informal consultations, and having those discussions, but not using the language, not using the tools, to have those conversations. Again, we set up the task system, the notification system for workers, and we do track. Actually, we have a data report that tells us if it was opened, if they accessed the CANs, and some workers are more consistent with that and than not. So we see some that are opened and some that just sit. Okay, this is my favorite topic, like the collaboration and communication, because when I worked as a clinician, I think back to the hardest cases, the hardest kids that I worked with, the kids that has experienced the most trauma, and think back to my interactions with the worker and how much that helped, right? So when I could, as a clinician, collaborate with the worker and the family, we saw so many better outcomes for youth and families. I know Farhad's given me the 10 minutes, so okay, we got to move it. So I'll stop talking about it. But seriously, we're really excited about this new study that we're doing, looking at collaboration. I think we're going to learn a lot about the state of affairs here in Kentucky. So. Collaboration varies by agency. It's different for different agencies. I will run through these. I think you all will have access to the slides if you want to check it out. This person says those private agencies tend to have better communication with community mental health. There's lots of referencing of turnover and burnout, and people leave and the kid has multiple clinicians and we don't know who to talk to. There are some, I guess the poor communication. I wish agencies would reach out and tell us, why the CANS wasn't completed. Maybe they've tried to reach the family. They're not getting the information they need. There are all kinds of reasons, but that's not always communicated back to child welfare. And they miss that. They need that information. Some workers feel that they collaborate more than our agencies do. We have lots of paperwork. Sometimes the workers are reporting that it feels as though the agencies are just reviewing the referral information and not reaching out and asking those questions. And again, other regions, we do see really good collaboration. I know in some of our regions, they have quarterly meetings with the child welfare staff and the community mental health center staff and other private agencies, and they're able to sit down and talk specifically about cases and what's going on. So we do see, and again, that's really a regional basis, not a statewide thing. So that's where it meets quarterly. Okay. So again, just running through those contextual barriers to the screening and assessment process overall: workload, turnover, not fully understanding the process, concerns about the quality of the assessments, lack of understanding. How many of you have heard concerns about screening or completing CANs on younger kids? Why are we doing this? And we really have struggled with that in Kentucky as well. We have concerns about timelines and accessing information as well. We do see with DCBS that they tend to use that multi-prong approach to gathering information from youth and families, but that communication and collaboration really varies from provider to provider. So some agencies do it better than others, but still that concern of lack of buy-in. So, all right, we're going to look at some administrative data before we wrap up.
All right. So I mentioned this was a mixed method study. So how to describe this in 30 seconds. There were like 8 systems of data that we all combined to do this. And what we're providing here are really just some of the basic findings. There's so much you can do with administrative data, as you may know. So youth screened who met the clinical threshold for a CANS, meaning one of the screeners that was completed by the child welfare worker, they met the clinical threshold for a CANS assessment by age. So I just want to show you the difference between 2018 and 2022. And specifically, I want to point out what Lizzie was just talking about. So this age 0 to 3, right, 32% met clinical threshold in 2018. That changed to 69% in 2022. So what does that suggest to us? It suggests that as child welfare workers are using these screeners over time, they are understanding trauma symptoms or understanding behavioral health symptoms in a different sort of way. Thus, youth are screening in, which is what we would want. We want child welfare workers to be more aware of what's going on so that they can refer the child to treatment. So then we want to compare that to CANS assessment by age. And what I'll just draw your attention to for time purposes. So you see here, it's the green bar there, age 0 to 3. So that has consistently dropped over time. And so that's an implementation drift issue, right? So Lizzie and I have talked about that. We're talking about bolstering supports, helping clinicians and behavioral health providers collaborate a little bit more around that particular group. So then we have CANS assessment by provider type. So Lizzie mentioned we have essentially 3 buckets of providers. So these are the PCC, PCP CANS over time. So if you'll look at the first CANS only and then subsequent CANS. So we broke it out this way because we were thinking that subsequent CANS is a proxy for continued treatment, right? So engaging in ongoing treatment, we were using that as a proxy mechanism for that. And what you see there is that. So, we have seen that drop over time. Spoiler alert, this looks really good. Okay, so before I advance, so just know this looks really good. Blue is good, right? Blue, good. Green, not so much. So in the CMHC CANS over time, we really see a fairly significant drop in youth getting continued CANS assessments. That does not indicate, again, it's a proxy, so it doesn't indicate treatment over time. It's just a proxy for continued treatment. And then we have independent providers, and we have a lot more green there as well. So lots of areas we know that we want to explore. We are looking at this like implementation drift over time, so bolstering supports. I think that's true for all of us. This is the first presentation I've done in front of people. So I don't know when, 2019, I'm sure. So anyway, I think we're all still shifting from COVID. And I would say that it's the same thing when we really think about this. So bolstering the implementation supports is really where we want to go with this. All right, Lizzie, bring us on home.
Great. So what do we hope to do in the future? Well, I mean, those compliance numbers would be one thing to focus on, certainly. But there has been expansion. And of course, with the Family First Preservation Services Act implemented in Kentucky, Kentucky was an early adopter. But there is a huge shift to focus on preventing youth to coming into out-of-home care. And so our Department for Behavioral Health, under their System of Care 5 grant, we're able to implement or expand screening and assessment to include in-home child welfare cases, so youth receiving those services in the home. In four of ours, okay, thanks, Dee Dee. 4 service regions, and as of August 1st of 2023, that has expanded to include the entire state. So all youth that are receiving in-home services should have a screener completed, again, to more better identify those concerns early on. But really going back to the basics of implementation. So what do we need to do? How do we re-engage, and look to those early supports that we offered, the monthly and weekly calls and check-ins to make sure that our providers feel supported and can, offer better training opportunities and get that buy-in. And then one thing that we've heard time and time again is we need more than compliance data, right? So we want to understand, is this process working? Are we making an impact? And so we are hoping to be able to increase the data analytics to really be able to look at that, to tie the screening and assessment data, together. And we have the ability to do it and hopefully have some investment around that as we move forward. So moving, not just compliance, but what does that really look like on the ground level? So I think that's it. And thank you for your time. There is a question. I see someone. Okay.
I have two quick questions, just because this is so weird to our experience in Massachusetts.
Ah.
One is that one of the things that we're finding is the question of when do clinicians get true baseline data?
Yeah.
When do they have enough of a relation? Because we see it looks like kids are getting worse in 3 months, but they're not really using that data. So I'm curious if you ever thought about when a true baseline should be, like when should it be due? And then my second question is thoughts you might have about, we've been hearing a lot about the technology can be a way to help implementation and to be useful for clinicians. And if you have things in your system that clinicians see that seem to help drive compliance and investment, what kind of reports are those? Sorry.
Yeah. So I think your first question is probably better answered by John or April. But my understanding and what we I believe, is the second cans is probably the more true cans. So, your first, you've only known the kid and the family for a couple weeks, 30 days. And then we'll see kind of a dip on the second because what appears to be regression, but just getting to know them better, you may have a better idea. So
I think that also, though, if you just think even logically about a kid's trajectory, so you have a youth in out-of-home care is going to have their best face forward because they don't want to be placed again. So I'm going to tell you everything you want to hear. And then as I begin to trust my care providers more and I continue to go to therapy, you may actually see some of the true baseline of what's going on with a kid. So, I would kind of look at it from that lens also.
Yeah. And then as far as clinicians, we have some reports available. We're excited because we're moving into a new system that has, better real-time data reports. But clinicians want to see the change over time. They want to visualize that in some way. One thing that clinicians want is email reminders of due dates because, they're in their own system every day, their own EHR. And if it's not tied to that, then, they just forget because, while I might be in the system every day, they're certainly not. So like external email reminders and due dates, things like that. So I don't know if we have time for, there's more.
What's your screener?
We have 7 of them.
Yeah, it's based on the child's age. We have the young child PTSD checklist, parts A and B, the strengths and difficulties questionnaire, upsetting event survey, child PTSD symptom scale 5, and the craft. Yes. They have to meet clinical cutoff on at least one of the screening tools, and we use, it's different for everyone. So, I can share that with you what the clinical cutoff is that we use.
They're all standardized
They're all
measures.
standardized.
So, they've been validated.
Okay. All right. Thank you.
Thank you all. Yeah.